Good morning, everyone. Welcome to TeleShadowing. We're live on YouTube. Feel free to ask questions as we go along and they will be addressed. So today we are going to be talking about clinical pathology, specifically part 2 of our series of this month on principles of neoplasia. So basically, I'm going to be going over a chapter from Pathoma, which is a book by Dr. Sutter. And essentially, he goes over the principles of cancer and how it's really applicable and forms the foundation of our understanding of cancer. So today we're going to be learning neoplasia, cancer, of course, and its epidemiology, carcinogenesis, the hallmarks of cancer, also clinical characteristics of cancer, including the feature, how it's diagnosed versus how it's screened for. And then finally, we'll be going over a case study to apply the knowledge that we've learned from last week and also this week. All right, so let's get into neoplasia basics. So first and foremost, neoplasia is actually referring to something called new growth. So when you contrast that to dysplasia that we learned about last week, dysplasia is actually disordered cell growth. So neoplasia means new growth. And essentially neoplasia is that step after dysplasia. Now that dysplasia is actually precancerous growth. Now neoplasia is uncontrolled and monoclonal proliferation of the cells. So neoplasia can be either benign or malignant. So there's this monoclonal proliferation of cells that we'll talk a little bit more about what does monoclonal mean on the next slide. But basically, this cell proliferation can be either benign or malignant. So what does monoclonal mean? Essentially, monoclonal means that the neoplastic cells are derived from a single mother cell, or I'll call it from here on like a single isoform. So now that you have that isoform, it's basically saying here that this new tissue growth that's unregulated, irreversible, and monoclonal, that's really what distinguishes this from this neoplasia from hyperplasia. So monoclonal means, again, that the neoplastic cells are derived from a single mother cell or single isoform. And basically, there are specific isoforms I won't get into now for purposes of time, but basically, an isoform is a type of enzyme specifically determined or historically determined, I would say, by glucose 6-phosphate dehydrogenase, G6PD, which is something we learned about during our MCAT. And essentially that there's this normal ratio of active isoforms. And as more research is being done, we've learned that there's a specific ratio that's maintained when there's hyperplasia, and that leads to polyclonality. So polyclonal means that cells are derived from multiple cells, whereas only one isoform is present in neoplasia, which is monoclonal. So this clonality can also be determined by various things, by your genes, by your environment, and also what chromosomes you have passed down from your parents. So I think that's like a very brief overview and I'm sort of skimming over the details. But essentially, this is really what I want to drive home, that neoplasia is tissue growth that's unregulated, irreversible, and monoclonal. It can actually progress from hyperplasia as well. You can see here, hyperplasia is different from cancer. Dysplasia is also different from cancer. Dysplasia means precancerous. Hyperplasia doesn't really have to do much with cancer per se. Hyperplasia can hypothetically lead to cancer, but remember when we learned about cellular adaptations last week, this hyperplasia can actually reverse once the cellular stress is complete, because hyperplasia can be physiologic. It doesn't always have to be pathologic. Remember what physiologic means? It means normal. So, for example, hyperplasia in breast expansion during lactation, that's completely normal. Or the uterine pouch expanding during pregnancy. Remember hyperplasia and hypertrophy. So that is a cellular adaptation, as is dysplasia. Dysplasia is also a cellular adaptation, but dysplasia is termed precancerous, and if the cellular stress is not alleviated, then technically, while dysplasia is reversible, cancer is irreversible. So cancer or neoplasia or new or disordered growth is a growth that's really not in the cell's control anymore. And we'll talk a little bit more about why does the cell lose control? We'll talk a little bit more about that.
Sure. I want to ask you pretty quick. So as you mentioned about dysplasia, so can you a little bit explain what is dysplasia? You mentioned the precancerous, but I would just like to add on. Basically, it's a terminology that describes abnormal cell growth. So as you're showing in the diagram, the normal cells, so there's an abnormal cell growth, or you can say it's a development in an organ or tissue, abnormal cell growth in an organ or tissue. And it can be mild, it can be moderate, it can be severe. So it depends on how abnormal the cells look like and how much of the tissue or organ is affected. So that's a dysplasia. And dysplasia is not always the cancerous, but it can sometimes become the cancer. I just want to clarify that. All right, go ahead. Thank you.
Yes, thank you, Dr. Chima. Yes, so I did want to make a distinction that dysplasia does not always mean that it's cancerous or that it's neoplasia. Dysplasia is different from neoplasia. So thank you very much, Dr. Chima. I appreciate it. So now I want to talk a little bit more about how is this growth supported? Because usually if you remember the cell growth cycle, and we know that there's interphase, metaphase, cytokinesis, and there's that cell basically life cycle that goes through from G1, G2, M1, M2. Basically, how does a cell sort of hijack this and supports the growth of growth that's not supposed to be occurring? So basically, neoplastic growth has two components. Number one, it has a component of the parenchyma. The parenchyma is basically the space within the epithelial tissue layer that holds and encompasses the neoplastic cells, and the supporting stroma, which is the second component. Now, why is it called a supporting stroma, you may be wondering? Because the stroma contains all of the non-neoplastic cell stuff, you could say, that they need to survive, such as blood vessels and connective tissue, and all the things that will provide the cell and help provide it nutrition and blood supply in order to keep the neoplastic cells growing. So I'll show you a diagram later on that actually shows you exactly how once the cells proliferate the epithelial cell layer, the blood vessels and so forth are actually supplying this, and the body and the whole, and essentially, like, tumors, they cannot work without this stroma and parenchymal support. If the host no longer supports that, then the neoplastic growth will not be supported and no more neoplastic cells would occur or replicate. So basically, excessive and unregulated proliferation eventually becomes autonomous. Autonomous means that basically basically this neoplastic growth becomes independent of all the physiologic or normal growth or inhibitory stimuli. So what that means is basically, if you don't have any more normal growth, there's always normal stimuli, there's always feedback loops that are being applied to our bodies, there's hormonal signaling going on. But regardless of this hormonal signaling, these neoplastic cells will not respond. So that's what it means by autonomous, even if their hormone is telling the growth to stop. So remember that neoplasia is unregulated and also irreversible. So that is the foundation of what we call cancer. So here as well, you can see here the parenchyma in this picture on the left-hand panel. There's parenchyma on the encapsulated inside cells, and that is actually where the neoplastic cells will reside, and the stroma is the rest of the supportive connective tissue. All right. So now here again, let's talk a little bit about dysplasia, just to reiterate from last week. So neoplasia and neoplastic progression refer to uncontrolled and monoclonal proliferation of cells. So again, the neoplastic growth has these two components. You can see here the epithelial cells on the left part of this left panel. The epithelial cells are part of the parenchyma, which includes the space that the neoplastic cells are in, and two, the supporting stroma, which is located below the basement membrane. So you can see the blood vessel, the lymphatic vessel, that is what supports these cells normally functioning, really. So in this first panel that you're looking at right now, you'll see that normal cells have a basal and apical polarity, and which show normal cells properly localized to where they're supposed to be. So there's something called a cytoplasmic to nuclear ratio. That's very important when we're looking at slides of these cells and biopsies. What that means is basically the nucleus is well demarcated. The nucleus is the appropriate size in relation to the rest of the cell. In the second panel, you'll see a loss of uniformity in dysplasia and shape. And you can see that the tissue orientation is off and there's nuclear changes, as in you'll start to see an increased nuclear to cytoplasmic ratio. You can see in the purple cells, in the purple blobs here, there are darker spots that represent the nucleus. And so those darker spots are a little bit bigger. So you can see it's a little bit thrown off, starting to look a little bit more disordered. So again, remember, dysplasia refers to disordered cellular growth as the cell adapts to stress as well, but technically it is reversible. And dysplasia only refers to precancerous cells. And in the third panel, you'll see here, this is called carcinoma in situ. This is the stage in which dysplasia becomes irreversible and will always progress to cancer. However, while it does involve the entire thickness of the epithelium, it's called a full thickness dysplasia. That is another word for carcinoma in situ. It does not yet penetrate the intact basal membrane. As you can see, let me get my pointer out, or here, you can see this is the basal membrane. And this is a carcinoma in situ. The basal membrane has not been proliferated yet. So, all right, there's that's panel 3 and the carcinoma in situ. And then in panel 4, this is when the carcinoma in situ has become and transformed into invasive carcinoma. You can see that the cells have invaded that basal membrane using various enzymes, specifically collagenases and hydrolases. And also the cell-to-cell contact that was keeping them normal in all the way on the left panel, they're actually held together by E-cadherin, which is an adhesion molecule expressed in most normal epithelial tissues. So when that E-cadherin is lost, there's no reason for these cells to continue to adhere to one another. And once that's lost, there's no reason for them to adhere to one another. And so they'll continue to grow out of control. And also notice the even more increased nuclear to cytoplasmic ratios of these disordered purple cells. And finally, in panel 5, there's metastasis, also known as the spread of cancer from distant organs via the lymphatics or the blood. So that's when, see, the cancer is completely taken over, and the host is actually supplying this neoplastic growth as it becomes various tumors or various masses that don't belong there normally. Okay, now we're going to talk a little bit more about the clinical characteristics of cancer. First, I'm going to differentiate between malignant and benign neoplastic tumors. So one usually may think that neoplastic tumors are always going to be malignant. That's what we consider cancer. But tumors can also be benign. There are also such things as benign tumors. I think that was something that I found very interesting when I was learning about this in my hem-onc unit in med school. So basically, let's start off with benign on the left. So benign tumors or benign neoplastic tumors are always well differentiated. Now, what does well differentiated mean? Basically, well differentiated means that the tumor always resembles the parent tissue, as in it has the same function, but it's unable to produce a lot of the autonomous, I guess you could say the negative feedback. So it'll produce a lot of the hormone. For example, in squamous cell carcinoma, there's a lot of keratin being produced, although carcinoma is considered a malignant tumor, but I'm jumping ahead of myself. But let's think about insulinoma. That's when there is a hypoglycemic patient fainting a lot because there's a lot of insulin being produced. It could be caused by a benign tumor. Another interesting thing about benign tumors is that they are mobile. What mobile means is that they are well demarcated and they're movable. And so that means that it's better able to be surgically removed because there is that well demarcated, this one spot of that tumor. And that leads to a better prognosis for the patient. So benign tumors, of course, would be a better prognosis for the patient. They're amenable to surgical removal, and they also remain localized. So benign tumors do not metastasize ever. There are some exceptions, but they don't tend to be malignant or really like threatening to the patient. So we'll stay with the generality for now. And so for everyone's purposes. And also another thing about benign tumors is that they also grow very slowly, generally speaking. There's an exception, like under the influence of some hormones, benign tumors can also grow fast, like in leiomyomas or fibroadenomas. But generally speaking, it's a general principle that benign tumors grow very slowly. Another thing about benign tumors is that they look like typical cells. Although they do have a low nuclear to cytoplasmic ratio, it's not at least increased. There's also minimal mitotic activity, so there's light chromatin in there. That probably plays into why that the cells are growing pretty slowly because there is a lower nuclear to cytoplasmic ratio, so the cells aren't as growing as fast as malignant cells, which takes us to the malignant tumors. Now, in contrast to benign tumors, malignant tumors tend to be much more poorly differentiated, which means that they don't resemble the parent tissue, but it can range from well, moderate, poorly completed, completely undifferentiated, dedifferentiated is another word for undifferentiation. That comes down to tumor staging and grading. So we'll talk a little bit more about that later in the presentation today. But basically, malignant tumors are unable to respond to negative feedback loops at all. So they tend to have a completely different or unexpected functions, a gain of function mutation, for example, in this type of cancer. Malignant tumors also tend to have poorer prognoses compared to benign tumors. And if malignant tumors become metastasized, they are not movable. They tend to be fixed. That's called desmoplasia, where basically they stick to, I believe, the chest wall, and they become harder or almost impossible to surgically remove from one area because it's spread to the rest of the body. Malignant tumors also grow much, much faster. There is an exception with the normal cells that have rapid turnover, like the epithelial lining of the gut or hyperplasia-related malignancies. But generally speaking, the general principle is that malignant tumors grow much faster than the slower benign tumors.
Okay, Minahil, I'm gonna
Yes.
just, as you mentioned, benign versus malignant, well differentiated and poorly differentiated. So I will go over pretty quick the pathophysiology. So what is the pathophysiology of cancer? So basically it involves several stages, and the first stage is basically the initiation. And what's the initiation process? In the initiation, there is a mutation occurs in the cell's DNA. So when there's a mutation occurs in the cell's DNA, that leads to the activation of the oncogenes. So oncogenes basically the genes that promote the cell growth, or you can say the inactivation of the tumor suppressor genes. Tumor suppressor genes basically the genes that inhibit the cell growth. And of course, cancer begins when body cells in the body begin to grow uncontrollably. And as you mentioned, the well differentiated and poorly differentiated. So basically, the what we do in cancer, the pathologic diagnosis usually includes the information about the cancer type, and there's a grade and stage. So grading is basically how abnormal the cancer cells look under the microscope. So that's called the grading. This is how we grade, and how quickly the cancer cells are likely to grow and spread. And the stage is basically the extent of the cancer in the body, the how far that cancer has been suppressed. So this is how we say it's a poorly differentiated or well differentiated, and then great. So you have any when you learn about oncology and cancer, the pathology diagnosis. So there's a grading and staging. So these are two things you need to keep in mind. All right, yes, move on.
Thank you, Dr. Shima. Yes, we'll be having slides on tumor grading and staging shortly as well. So now that, as we were saying, that the invasive malignant tumors have a lot of metastatic potential, such as in a leiomyosarcoma. They also tend to have pleomorphisms, which basically mean a cytologic and nuclear atypia. That basically means that the cells are atypical. They have a higher nuclear to cytoplasmic ratio, like we saw in the previous slides. There's hyperchromatin also there, as in there are larger nuclei, which basically indicate that these cells are growing much faster and duplicating much more. There's also something called anaplasia, which means a lack of differentiation and extreme nuclear abnormalities. And finally, as I was saying, because as a result of having this greater and larger nucleus, there's higher mitotic activity, and you would see hyperchromasia under a microscope and atypical mitotic figures during mitosis. So this is actually why we learn normal mitosis and meiosis, so that we know what happens when things go wrong in cancer. All right. And this is actually what benign and malignant tumors look like. So we'll look at benign first. So you can see here, this is what I mean by well demarcated or well defined, right? So you can see here that the tumor is mobile. There's a fibrous capsule you can see in red on the and yellow highlight at the bottom. And in T means tumor, N means the rest of the lymph node. So you can see easily that the tumor is well demarcated. It's easier to be surgically removed than if it were not well demarcated. You can see here in a malignant tumor, this is what ductal carcinoma of the breast can look like if it is malignant. And you can see that there are nests and cords of these tumor cells, and there's also desmoplasia, which means that the tumor is too hard to remove. And there's also an absence of a well-defined capsule of these neoplastic cells. So I hope that that visual gives you a good difference between like benign, well-defined tumors versus non-well-defined tumors. And also here on a like a pathologic slide, we also tend to see the histology behind it all. So benign tumors, like I said before, are usually well differentiated. They on the left, you can see that's much more well differentiated. There's uniform nuclei, there's organized growth, there's a lower nuclear to cytoplastic ratio, there's minimal mitotic activity. There's also a lack of invasion of the basal membrane or local tissue, and there's also no metastatic potential. Whereas on the right-hand histologic slide, this is of a malignant tumor of anaplastic carcinoma of the thyroid. You can see here that malignant tumors are classically poorly differentiated. There's like disorganized growth because of the lack of the loss of polarity in the nuclear mitotic figures. There's nuclear pleomorphisms and hyperchromasia, which basically means that the chromatin is much more dense. So that's why we're seeing it much more bigger and darker on these histologic slides. There's also high mitotic activity. There's atypical mitosis going on, and there's also invasion that can be seen through the basal membrane into the local tissue. Another thing about this is that metastatic potential is the hallmark of the malignancy that benign and also benign tumors never metastasize. So here you can see the basal membrane has basically been penetrated, whereas here it's not. You can see these are well demarcated lobules and glands. And another example, I just wanted to really derive from the point of benign versus malignant. On the left, you can see a leiomyoma, and on the right, you'll see a leiomyosarcoma. So I'll talk a little bit more about how you can easily tell between what is benign and what is malignant just by their names. For example, sarcomas refer to malignant cancers, and anything ending with a oma tends to usually mean a benign tumor. So you can see here, again, well demarcated, slow growing on the left, whereas on the right, it is larger, it's poorly demarcated, they're rapidly growing, there's hemorrhage, necrosis happening. It tends to be invasive, local to the tissue that's being affected, and it's metastatic. All right. Now, I wanted to just kind of talk one more time, I guess, about the commonalities between benign and malignant tumors. So again, benign tumors, essentially, they remain localized and they do not metastasize. So it's really, I'm sort of highlighting the main difference between benign and malignant tumors. Whereas malignant tumors, they tend to invade locally and they have the potential to metastasize. So all benign and malignant tumors have the following things in common. Number one, of course, they are monoclonal, but the things that all tumors basically have in common, whether they are benign or malignant, include excessive unregulated proliferation, excessive and unregulated proliferation that also becomes autonomous. Remember, I said before, autonomous means to be independent of all physiologic growth or negative feedback and inhibitory stimuli. Number two, the dependence on the host for nutrition and blood supply in order to keep proliferating. And number three, there's only one isoform present in neoplasia. AKA these neoplastic cells are all monoclonal, derived from the same isoform. So I wanted to briefly touch on carcinogenesis and the hallmarks of cancer. Now, the hallmarks of cancer, carcinogenesis, there are classes that are taught in undergrad. I remember taking a class in undergrad called the biology of cancer. And I'm not doing this lecture justice because I remember we spent one lecture per each hallmark of cancer, and each lecture was 45 minutes long. So of course, there's more research being done, and there are many more molecules that I'm really just skimming over. But basically, the basic principles of carcinogenesis, as Dr. Chima was saying, is that the cancer formation is initiated by damage to DNA of stem cells. And so this damage, once it overcomes the normal DNA repair mechanisms that we have, it's not lethal enough for the cell to sort of commit apoptosis or programmed cell death, but they're carcinogens that are agents that damage the DNA. So for example, when you think about smoking and lung cancer, smoking or the nicotine in smoke is a carcinogen, a known carcinogen to cause lung cancer. So they are the agents that damage DNA in cells that increase the risk of cancer. So important carcinogens include like chemicals, oncogenic viruses, and also radiation. So DNA mutations, they eventually disrupt the key regulatory systems that allow for tumor promotion, like tumor growth, and also progression of that tumor. So you can see here on the left is the normal cell cycle, and on the right is like a cancerous cell cycle. So the most important molecule I would say I would want to reiterate is P53. P53 is an oncogene that basically once it's deactivated, the cell no longer can basically keep itself in check. And so as a result, basically damaged cells keep on replicating and that is what causes eventual pathologies and clinical symptoms. But going back to the hallmarks of cancer slide, basically this is all what can classify cancer, really. So I can start from the top: evading growth suppressors, non-mutational epigenetic reprogramming, avoiding the immune destruction of cells. Basically, sometimes cancer cells can sort of pretend that they are basically cancer cells can pretend that they are real cells, normal cells, physiologic cells. So that's what I find very interesting sometimes, and that's how they're able to avoid immune destruction and sort of fool the immune system into thinking that they are normal. Then there are disrupted systems. They include proto-oncogenes, tumor suppressor genes, and also regulators of apoptosis. So P53 is a very important tumor suppressor gene. Once it is no longer there, the P53, then that means that tumor suppressor gene is off, which means tumors are no longer being suppressed, which means the cell won't go into apoptosis if the cell does detect something wrong with itself, and it'll continue to replicate while it is an abnormal cell. Um, that basically it's like basically hijacking or hacking into your cells. That's basically what cancer does to your body. And let's talk a little bit about oncogenes. So oncogenes or proto-oncogenes, they're essential for cell growth and differentiation, but the mutations in proto-oncogenes, and basically these are genes. Proto-oncogenes have the capacity to lead and form into oncogenes if they are mutated. But otherwise, proto-oncogenes in a normal way, they are very important for cell growth and differentiation. But if they're mutated, then they can lead to unregulated cellular growth, which can lead to cancer. So categories of oncogenes include like growth factor receptors, there's signal transducers, nuclear regulators, and cell cycle regulators. I'm not getting into all those molecules now, but we do need to know them within our first 2 years of medical school before taking the step 1 exam. But the growth factors, for example, like there's growth factor receptors that mediate signals from other growth factors, such as like there is a growth factor called ERBB2, which is important for breast cancer. There's also signal transducers that relay receptor activation to the nucleus called RAS. So basically, they're just 2 examples of many, many other examples, and also genes that can be turned on or off. Basically, a lot of things can go wrong and cause cancer. So again, here, like I said before, once the P53 is disabled, apoptosis is disabled. So with nothing to stop tumors from occurring, the damaged DNA will continue to keep growing and growing and growing until it's ready to go into mitosis and eventually just keep replicating, keep having more and more mutations in cells, and that's what causes these masses to form in the body eventually, as long as it continues to be like disordered cell growth and there's no treatment to treat it. Now let's talk a little bit about tumor nomenclature. Nomenclature is basically is a Latin derivative for how to name things. Like nomen means name in Latin, so nomenclature would mean how you're naming things, naming tumors basically. So tumors are basically named by their lineage. So AKA the type of tissue that's being produced, whether it's like a fat tissue, epithelial tissue, any type of tissue, and whether the tumor is benign or malignant. That's sort of the general principle behind tumor naming. So if it's a benign neoplasm, like I said before, it will end in OMA, O-M-A. But if it is a malignant epithelial neoplasm, it will be termed a carcinoma at the end, the suffix. And if it's an like let's say if it's a malignant neoplasm from a mesenchymal or connective tissue, that is then called a sarcoma. So connective tissues are different from the epithelial tissues, as we'll see in the next slide. But basically, this is from my notes directly, like when I was studying this, the sarcomas and adenomas, and I was sort of contrasting what is a benign tumor versus a malignant tumor. For example, like adenocarcinoma is a malignant tumor of the glandular epithelium, whereas an adenoma is a benign tumor of the glandular epithelium. Now, similar to like fibrosarcoma in pink, it's a malignant tumor of fibrous tissue, but a fibroma is a benign tumor of fibrous tissue. So these are very interesting things to keep in mind, and an easy, I guess you could say, hack to understand. Just generally, if it ends in oma, it's referring to something that's benign. If it's ending in carcinoma or sarcoma, then it's referring to something that is malignant or something that is poorly differentiated. And this is taken directly from the Pathoma textbook, table 3.1. Basically, again, we're naming things based on the type of tissue produced. So again, you're looking at the epithelium, adenoma, adenocarcinoma would be the malignant version of the benign adenoma. Or, for example, if it's in the mesenchyme or the connective tissue, a lipoma, lipo is referring to fat, so a lipoma, or a liposarcoma, so a fat-related, a malignancy, liposarcoma. And there is an exception. It's basically a malignant skin cancer is called melanoma. So it is ending in oma. So that is one exception to the rule, because a benign a skin cancer, or well, it wouldn't be called cancer. A benign tumor would be called like a nevus or a normal mole that you see on your body. But a melanoma is a malignant skin cancer of a melanocyte. Remember, melanocytes are derived from melanin in your skin tissue. Now let's switch gears into the epidemiology of cancer. Let's focus a little bit more on malignant cancers specifically and its epidemiology. So the global cancer incidence is 18.1 million new cancer cases every year, with the most incidences occurring in Asia. Most likely, there are maybe multiple reasons why, but I would also sort of look at the statistic and also think where is the world's population most concentrated, and that is in Asia, including China and India, of course. So sometimes statistics like these need to be taken with a grain of salt. You also want to look at what is the population relative to the area mass, and so this is divided by continents, but then you also have to think about what is the population on each of these continents, right? So this is just giving you just a global view, a global perspective. So after Asia, then Europe is 23% and America is 21%, the number of cases relative to their population. And then I wanted to also mention that cancer is the second leading cause of death in both adults and children. So the number one leading cause of death in adults are cardiovascular disease, number two, cancer, and number three, chronic respiratory disease. Now, these numbers changed a little bit during the pandemic, but they've re-stabilized, I guess, to these standard numbers outside of pandemic numbers. So this is very interesting to learn and think about. So when people are talking about cure for cancer, they're all different types of cancers, and cancer is most usually referring to malignant types. And there's also lymphomas, which are considered blood cancers, which is not something we're going to be talking about today, but also something to keep in mind. And then finally, just splitting it by gender, like the most common types of cancer in the United States. So the most common cancer by incidence in adults are number one, breast and prostate cancer. So breast cancer in females and prostate cancer in males. And the second most common is lung cancer. And number three, the third most common type of cancer in the US is colorectal cancer. And so these are all excluding skin cancers. Skin cancers are just not classified here, primarily because we want to focus more on systemic diseases. And so here, also excluding skin cancers, the most common causes of cancer mortality or cancer death in adults are number one, lung cancer, because there isn't much screening available for it. And that's why physicians advise for lifestyle modifications like smoking cessation, given easy detection is, detection is hard to accomplish basically in lung cancer, or early detection is difficult to accomplish. And then the second greatest cancer leading to mortality or death is breast and prostate cancer. And the third most common is colorectal cancer. Liver and bile duct cancer are mortalities are also trending upward because of the increased prevalence of hepatitis C. So these are all just factoids that I wanted to share with you so you can keep them in mind for when you're thinking about breast cancer, just cancer in general. All right, so I wanted to also talk about cancer as a whole, and when you're thinking about cancer screening, so remember, cancer begins as a single mutated cell. So approximately 30 divisions occur before the earliest clinical symptoms arise. And each division, or also known as like a doubling time, results in increased mutations. So you need about 30 of these doubling times before you experience the earliest clinical symptoms. And so cancers that don't produce symptoms until late in the disease will have undergone additional divisions and therefore additional mutations. And so that's why lung cancer, because it's hard to detect early, most people detect a little bit later in life. And so that's why smoking cessation is so important. And so cancers that are detected late tend to have a poor prognosis, and a prognosis just means a poor outcome for the patient, right? We want to have better prognosis for the patient. You want them to have a full-on cure or go into full remission after cancer or be completely cured. Whereas a poor prognosis would be the opposite of what I just described. So there are two goals of screening. Number one, screening seeks to catch dysplasia, which is the precancerous change before it becomes carcinoma, or to detect carcinoma before the clinical symptoms arise. But the efficacy of screening requires a decrease in the cancer-specific mortality. So basically, in order for screening to be more efficacious or more effective, um, I'm really just I guess he's explaining in an elementary way, but basically in order for screening methods to be more efficacious, to lead to diagnoses, and of course screening is different from diagnosis. I'll talk about that in the next slide, but basically they require a decrease in the cancer-specific mortality based on the type of screening modality used. On the right, I believe that's like a clip art of an ultrasound, but that's of course not what it would look like. Basically, the patient will be laying down and the ultrasound probe, also called now known as POCUS, can also use and can be used on breast tissues and look at and visualize different lymph nodes, etc. So now let's talk about common screening methods. So first, there's something called a pap smear. Pap smears are used quite often in the primary care practice for patients every few years, and depend the age of the patient, also the family history and whatnot. Sexual history also also vary the guidelines on how often a patient should be having a pap smear. But the most standard, I believe, is every 5 years. Basically, pap smears detect the cervical dysplasia before it becomes a carcinoma. And it's really good to have it proactively because a prevention is better than a cure. And then there's a mammography. A mammography, they can detect, this is a screening method that's very common that detects in situ breast cancer before it can invade or become invasive carcinoma before it becomes clinically palpable. Then there's also a PSA or prostate-specific antigen and digital rectal exam to detect prostate carcinoma before it spreads. And PSA is basically a type of protein that's released by the tumor into the serum, which makes it a serum tumor marker, useful for screening and also monitoring response to treatment regimens, and also like the monitoring of any recurrence of cancer. But the only way to diagnose the cancer and grade and stage and essentially classify what type of cancer it is actually just through a biopsy, whether it be a fine needle aspiration biopsy, a corneal biopsy, or a laparoscopic biopsy, and actually having a pathologist actually classify what type of cancer it is. And then finally, there's also a colonoscopy. So this is not an exhaustive list of all the different types of screening methods. It's just the most common ones that I could find. And so colonoscopies, they also detect the colonic adenomas before it becomes like a colonic carcinoma, right? Adenomas are benign, but carcinomas are malignant before it spreads. So speaking of grading, switching gears a little bit into tumor grades. So a tumor grade is essentially a microscopic histologic assessment of the differentiation of the tumor itself. So basically, you're grading how much the cancer resembles the tissue in which it grows. Remember, I was talking about the parent tissue, the normal tissue, and that will take into account the architectural and also nuclear features of the tumor itself. So a grade of 1 of the tumor means it's well differentiated. That's a low grade. It resembles, which basically means it resembles parent tissue, the tumor. A grade of 2 is a little bit higher. A grade, basically 2 or 3. 3 is worse. It's a higher grade, so it's even more poorly differentiated. That means it resembles the parent tissue a little bit less, so it's more poorly differentiated. It does not resemble the parent tissue. And remember, basically, grading is very important to determine prognosis because well-differentiated cancers have better prognosis than poorly differentiated cancers. So here is another example of tumor grading. So you can differentiate between grade 1, 2, and 3. Grade 1 is the lowest grade, which tends to have a better prognosis. And you can see in Gleason's pattern, a well-differentiated versus a poorly differentiated or anaplastic. Anaplastic means very different from parental tissue. And so you can see on the all the way on the bottom that that's not what all the way at the top or grade 1 looks like. And then there's cancer staging. Now, cancer grading and staging are different. Basically, cancer staging assesses the size and spread of the cancer. This is actually a key prognostic factor, which is actually more important than the tumor grade itself. Staging is just much more important than grading, primarily because of the system it uses, the TNM system. T stands for tumor size, N stands for node status, or spread to regional lymph nodes, which is the second most important prognostic factor, but primarily because of M. M means metastasis, which is the single most important prognostic factor, which is actually why I highlighted it in yellow. So, actually, cancer staging tends to be determined after the final surgical resection of the tumor from a biopsy or just when it's being taken off. And so the staging utilizes this TNM staging system. And again, staging is superior to grading in a prognosis and also diagnosis of the patient's cancer. All right, so I wanted to also practice TNM staging with you all. So I'll do this example and then we'll do the next example next. So a patient is diagnosed with a breast tumor measuring 3 centimeters in diameter with no extension to the chest wall or skin. No regional lymph nodes are involved, and there's no evidence of distant metastasis. What is the TNM classification of this case? So let me get out my marker really quick. Let's see if I can find it. Yeah, here we go. I'm annotating now. So let's see, let me test. There we go. Good. So basically, I want to find my T first. T, N, and M. So T means tumor size. So I'm told that this tumor measures 3 centimeters. So if I'm looking at my tumor grading scale, it cannot be a T1 because it's more than 2 centimeters, but it does fall under T2 because it is 3 centimeters and it falls between the 2 to 5 centimeter range. So that means that this tumor or tumor size is going to be classified as a T2. Now let's look at N. N means node status. So let me read this again. No regional lymph nodes are involved. So that means that if the surgeon can't feel any lymph nodes, then that would be an N0. But if the surgeon can feel or someone can feel lymph nodes, then it would not be a 0 anymore. It would be like an N1 and it depends on how swollen they are or how far they have progressed based on where they're located for the patient. So it would be N3 if it's near the collarbone. And there are some other, it's pretty variable, but I would say like if there's no node involvement, then it is definitely an N0. And finally, it says there's no evidence of distant metastasis. So that means that this would also be an M0. Metastasis doesn't have like an M1, 2, 3, 4 example and metastasis is either just yes or no. So there's either going to be a 0 or a 1. And in this case, let me just clear my annotations. Let's just clear it all. Yeah, so essentially, now we know that the answer to this question is going to be T T2, N0, and M0. So for the breast cancer patient with a 3 centimeter tumor and no regional lymph node or distant metastasis involvement, the TNM classification would be T2, N0, M0. This staging actually reflects a tumor size of 2 to 5 centimeters, which would mean T2. There's no regional lymph node involvement, that means an N0, and there's no distant metastasis, which makes it also an M0. And remember, metastasis can either be M0 or M1. And remember, that is the single most important prognostic factor for a patient. Now, I want you to do this and try this by yourselves. In this case, there's a patient with colorectal cancer. The tumor has invaded through the muscularis propria, which was measured. I'm just giving this to you. But if you did have an understanding of anatomy, you would not be given the length of the tumor. You'd have to sort of make that implication yourself. But let's say it is 7 centimeters in length, but not into surrounding tissues or organs. One regional lymph node shows signs of cancer, but there is no distant metastasis. How would you stage this cancer using the TNM system? So I'll pause for a bit, let you try it yourself, and I'll just give you a couple of seconds, and then we'll go over the answer. Or you can just pause the video, or try it on your own as well if you're watching live. Okay, I hope you had some time to go over it. So I'll go over it with you all. So basically, this tumor that is 7 centimeters in length means that this is a T3. The reason why it's not a T4 is because it specifically mentioned that it didn't penetrate into the surrounding tissues or organs, so it didn't break through skin or attach to the chest wall. So it can't be a T4. It would be a T3. Okay, and then as for the N, I would have to say that if there is well, it can't be N0 because there is a feeling of lymph node. Now, how specific are these lymph nodes? Let's see here. I would have to grade this anywhere between, hold on, where's it gone? Okay, no worries. Basically, since the surgeon can feel nodes that are located, I guess you could say near the lymph node, because I guess it didn't specify, but let's say it did specify, you would be correct if you called it N1, N2, or N3. I'll give it to you because it didn't specify. But here in this case, I called it an N3, but of course, anything from N1, N2, N3 would have been sufficient if you had enough information. And then there is the question of metastasis. So it's just yes or no. So if it's no, then it's M0. If it's yes, it did metastasize, then it'd be M1. So this would be an M0 because again, there was no distant metastasis. All right, so I hope that sort of clarifies things on how to actually stage TNM. There will be a question about it on the quiz as well. Again, yeah, oh yeah, so it was N1. So T3, N1, M0. So that, because it didn't specify, so N1 makes the most sense. All right. Now we're going to apply what we've learned so far in a clinical case scenario, and also apply what we've learned from the diagnostic methods, and also have a patient come in and we'll go over her history and do all the history taking that we learned so far this year and move on. So there is a case of a 36-year-old female with an enlarged axillary lymph node. And the axilla is located by the armpit. Axilla is just the medical terminology for armpit. So we call it axilla. And so this patient is complaining about it. And so let's first think about a differential diagnosis. Without any further information, I would ask, what is going through your mind right now from the different diseases that you know of as of now? So we could think, of course, breast cancer, metastatic breast cancer, or it could be reactive hyperplasia. We do need more information as to why we think it might be hyperplasia or a lymphoma, because again, lymph nodes can just, it doesn't necessarily always have to do with the breast being involved in the pathology. But let's do a clinical evaluation and see the patient now that we've reviewed their chart. So we will first ask them questions regarding their history. So have they had any pain, any recent infections, any fever, night sweats, weight loss, unintentional weight loss, changes in their breast tissue, or any family history of cancer? Those are the main things I'd want to ask because these are all related to a cancer diagnosis. I'd also do a physical exam and examine both of the breasts, not just a singular one on the right side. This is a patient complaining about the right side, but I would want to compare it to the left side as well and compare the axillary regions on both sides, so I'm not missing anything. I'd also look for any lumps in the axillary regions bilaterally, any skin changes or any other abnormalities. And so, before I get into, I guess you could say, and the next few slides, I will summarize my HPI or history of present illness. So this is a chief complaint of a patient who reports noticing a swollen lymph node. Now this is just me if I was giving like an oral presentation to my attending. So the patient reports noticing a swollen lymph node in her right axilla approximately 3 weeks ago. She is currently breastfeeding her 8-month-old infant. So that is something I didn't tell you before. We didn't know that until we actually asked the patient, like, are you lactating? How many kids do you have? Things like that. We do need to know. So this is now the history of present illness. Approximately 3 weeks prior to presentation today, the patient noticed a firm, non-painful swelling in her right axillary area while showering. She initially attributed the swelling to changes related to breastfeeding, but became concerned as the node did not decrease in size and was unaccompanied by symptoms of infection such as redness, warmth, or tenderness. The patient denies any fever, night sweats, significant weight loss, or unintentional weight loss, or other systemic symptoms. She reports no changes in the breast tissue itself, such as lumps, skin changes, or nipple discharge. There's also no past medical history of this patient, as in no previous history of serious illness or surgery. She has no known allergies. This patient is gravid to G2P2, which basically means that this patient has been pregnant 2 times and also given birth 2 times. So she has 2 kids. One is that infant that she's currently breastfeeding. So G2P2 with uncomplicated pregnancies and deliveries, and she's currently breastfeeding. The family history includes the mother was this patient's mother was diagnosed with breast cancer at the age of 54, and there's no other known familial history or cancer or other genetic disorders. So there's a red flag here. Family history. Family history is very important here. That remember, breast cancer is genetic. There is the BRCA1, BRCA2, BRCA1, BRCA2 genetic mutations that we'll get into later. Now let's talk about the social history. Social history basically goes over smoking, social drinking, what the patient works as, their occupation, who they live with at home. So this patient is a non-smoker with occasional alcohol consumption on the weekends. She works as a graphic designer and mainly has a sedentary lifestyle, because you also want to ask about the patient's diet and any exercise that they may be doing. The patient lives with her husband and 2 children. As for the review of systems, where I asked the patient these things, like generally, she denied weight loss, fever, fatigue, denied or no skin rashes, no itching, and on the breast, she did not. When I asked her, she said that she felt no palpable masses, no skin nippling, no nipple retraction noted, also on her self-exam. As for the respiratory, cardiovascular, gastrointestinal, or neurological review of systems, there were no other complaints. As for the physical exam, the vitals looked all normal, blood pressure of 120/80, heart rate 72 beats per minute, temperature 98.6 degrees Fahrenheit, so textbook perfect temperature, and respiratory rate of 16 breaths per minute. General appearance of this patient, she was well-nourished, a well-hydrated female in no acute distress. Lymphatic-wise, there was, in fact, that I felt on my physical exam of this patient, an enlarged and firm, non-tender right axillary lymph node, approximately 2.5 centimeters in diameter. There were no other palpable lymph nodes, basically. As for the breast exam that I performed with a witness as well, there were no masses, no skin changes, no nipple discharge, as the patient described. There was also no breast tissue, and the breast tissue was also consistent with lactation. There are other systems that I looked at. The physical exam otherwise was unremarkable. As for the diagnostic plan, to sort of figure out what's going on with the patient or what was the cause of this enlarged axillary lymph node, I would want to order like a mammography or an ultrasound of the breasts and also the axilla to assess the axillary lymph node and any other breast abnormalities. I'd also want to do like a fine needle aspiration biopsy of the axillary lymph node itself to sort of check it out and do a cytological evaluation, also and then based on those results, we'll decide if we want to do like a genetic testing based on what we see. And also blood tests, including like a CBC and also inflammatory markers, because we want to rule out from our differential diagnosis the different pathies, basically. If you want to rule out that it's not like a blood cancer or like an infection running systemically, you want to rule out infection or other systemic causes before you sort of get, jump into the most obvious thing, right, of breast cancer. So the mammography looks like this. It's essential for detecting abnormalities in breast tissue, especially for suspected breast cancer or atypical ductal hyperplasia. We'll talk a little bit more about what is this hyperplasia word I'm throwing around now, because we learned about hyperplasia last week. And also the ultrasound can also be useful for examining the axillary lymph nodes as well as the breast tissue more closely, and particularly in younger women with more dense breast tissue. So these are the mammogram results. These are sample results, of course, but I'll describe what we're supposed to be seeing and also what we're actually seeing in these pictures, because this is a case study we made up. So on the right breast, the mammogram results or the report said that there is a 2.5, 3 centimeter irregularly shaped mass with spiculated margins located in the upper outer quadrant of the right breast. The mass is of high density, so we're talking about the mass itself on the top right, and relative to the surrounding glandular tissues. There are also several smaller satellite nodules that were noted in this primary mass. There are also calcifications noted, specifically microcalcifications present within this mass. But the left breast was normal. There was normal glandular architecture with no significant masses, distortions, or any calcifications observed. And I also wanted to point out here on the left white arrow, remember, basically, my right, so I can actually write this down. So when you're looking at the screen, technically this is our right and this is our left, right? When just us looking at the screen. But but we want to go by the patient's left and the patient's right. So this is actually the patient's left breast, and this is the patient's right breast. So the one that we're focused on is the right breast. This pink arrow here that I'm showing demarcates that axillary lymph node, and this is basically showing. So we'll just focus on the right breast for right now. The left breast appeared normal, and this was the lymph node that was palpable, but there are still some other ones that I'm describing in my report of other ones that were not super palpable, but they're still present and they're there. All right, so now that we've looked at the right axilla lymph nodes, a lot of them are visualized, the largest measures to be 2.5 centimeters. The nodes appear to be fixed to one another, suggesting an N2 stage, but there's no evidence of necrosis. And necrosis basically means like tissue death or inflammation, or actually more and more inflammation in there. And then there's like necrosis also represents like more and more pus and more, and we're going to talk about this next week. We're going to talk about inflammation and chronic markers of inflammation, which includes necrosis. So a little bit of a spoiler for next week, but we'll talk about that a little bit more then. So basically the impression is that there is a high suggestion of a malignancy. The features of the mass and the fixed nature of the axillary lymph nodes are concerning for an advanced local disease because there is some local invasion. So it has been recommended to do like a core needle biopsy of the breast mass and a fine needle aspiration of the axillary lymph nodes for further evaluation. And if you wanted to do like a TNM clinical staging, since the tumor is more than 2 centimeters but less than 5 centimeters, it would be T0, T1, T2, or T3, or T4. It would be a I believe it would be like a T2. And then as for the metastasis to the axillary lymph nodes, I already gave that to you, N2, but there are no sign of distant metastasis, so there would be a M0. Of course, it has locally invaded, but that's not what metastasis means. Metastasis means that it's invaded like outside of the system itself. It's been distantly metastasized. So as for recommendations, you'd want to refer this patient to oncology, to a breast surgeon and oncologist for further management, and also have a discussion regarding the genetic testing I was talking about earlier. Because of the patient's age and the aggressive nature of the tumor, you want to know what type of mutation caused this breast cancer itself. So again, this is T2, N2, M0. So I hope that sort of gave you a bit of an overview of how we can sort of apply the pathophysiology of cancer, grade it, stage it, look at it a little bit more, and see how it's actually applied in clinical practice. And so we wanted to try finding out the cause a little bit more. And so since we're in our pre-curriculum in medical school, we can also connect this to something called atypical ductal hyperplasia. It can be caused by, so remember, the breast tissue normally, when it is lactating for a child and an infant is actively breastfeeding, females can present with atypical ductal hyperplasia. Remember, hyperplasia is physiologic. It's normal in patients who are breastfeeding. It's not pathologic. But if it is atypical, it can lead to cancer. So you can see on the bottom, in the cross-section of the milk duct, the cross-section of it, that's what the healthy duct looks like. The atypical ductal hyperplasia basically means that there has been an overgrowth of these cells, and it can be caused, there is research that shows that it can be caused by a BRCA1 or BRCA2 mutation. Which can lead eventually to ductal carcinoma in situ and then eventually breast cancer. So this patient unfortunately did progress to breast cancer. However, the good news is that it is well localized. So this patient would likely have a better prognosis than if the patient had it metastasized or a poorly demarcated type of cancer. So the biopsy, when we did the biopsy, that's how we sort of find out if it is ADH or not, or caused by ADH, but the microcalcifications are also indicative of ADH, the atypical ductal hyperplasia. So that's just one way I wanted to connect last week's material about cellular growth and adaptations and how physiologic adaptations can sometimes lead to cancer. And of course, that's not a one-size-fits-all rule. Of course, the family history plays a role, age plays a role, environmental factors play a role. And so our understanding of cancer is still changing, rapidly changing, as a matter of fact. So I hope that this was this is a very brief overview of the principles of neoplasia. If you are interested in learning more, feel free to check out the pathoma chapter on, basically it'll go over on all the specific oncogenes, the proto-oncogenes. It's very, very fascinating, very interesting. But I would say that this is a good way to get a head start before starting your hem-onc unit in medical school. So with that said, I'm going to be concluding today's session, and the link to the quiz is now live. You'll need a 70% or higher, as always, to pass and receive a certificate for attending today's session on teleshadowing.com/certification. And our next session will be on inflammation and immunodeficiencies. We'll learn about when you cut your finger and it sort of swells up. Why does it swell up? So I really liked, I love that topic, learning about it last semester. So I'm excited to share that with you all and looking forward to seeing you all at our next session.